Hello, my name is Sami Khella, and today I'm joined by Dr. Morie Gertz and Dr. Amanda Peltier, who are going to be talking about transthyretin amyloid polyneuropathy, the hereditary type. I would like to thank AstraZeneca Pharmaceuticals for providing the educational grant to support this activity. I would like to thank Vox Media for sponsoring the program. And if you would like to view this program again, it will be posted online shortly after the conclusion of this live broadcast at cmeplanet.com. To make you aware, there will be further programs at CME Planet on Twitter and other social media. So navigating the complexities of recognizing, diagnosing, and treating transthyretin amyloid polyneuropathy is the topic today. Dr. Gertz is going to talk to us about strategies for screening and diagnosing ATTR polyneuropathy. Morie?
Thank you, Professor Khella. There's a major educational gap in arriving at a diagnosis of ATTR peripheral neuropathy, and these delays come at a price for our patients because they suffer progressive and sometimes irreversible peripheral and autonomic neuropathy. These are my disclosures. A brief summary: ATTR amyloidosis is rare, but it is progressive and invariably fatal, and it's characterized by the widespread systemic deposition of amyloid fibrils in multiple organs, but particularly for ATTR, the myocardium and the peripheral and autonomic nervous system. In ATTR amyloid, transthyretin, the protein responsible for the transport of thyroxine and retinol, dissociates, is unstable, and forms amyloid fibrils in tissue. There are two types. There's a wild-type ATTR amyloid. No mutation is present. TTR is deposited primarily in the myocardium of individuals over the age of 60. Hereditary ATTR amyloidosis is caused by deposition of a mutant and subsequently wild-type TTR on the scaffolding throughout the body at any age. TTR is encoded by a single gene mutation, but over 120 mutations have been identified in the 4 peptides. Hereditary ATTR amyloidosis is transmitted in an autosomal dominant manner with variable penetrance, but as I'll show you, there's a preponderance for males. And although specific genotypes are associated with predominant neurologic or cardiac, in the majority there's a lot of overlap, and patients will have a phenotype that is both cardiac and neurologic. And you can see from the bar graph selecting 4 mutations in wild type, you can see there's a very, very broad variation in the frequency of sensory neuropathy, autonomic neuropathy, diarrhea, and cardiomyopathy that will range anywhere from 30 to 80%, but almost any organ can be involved with any mutation. Estimates are difficult to come by, but it's thought there are about 50,000 individuals worldwide with the hereditary form of ATTR amyloidosis, 10,000 with a polyneuropathy phenotype, 40,000 with a cardiomyopathy phenotype. But it's pretty clear that this is thought to be significantly underdiagnosed, and patients die of heart failure with preserved ejection fraction or an undiagnosed progressive peripheral and autonomic neuropathy. In the United States, the median age at onset is 68 for the hereditary ATTR, and the genotype, the mutation, determines life expectancy. It can range anywhere from 3 to 15 years, but it depends on region, specific genotype, extent of cardiac involvement. And although this is autosomal dominant, you would guess the ratio of men to women would be 1 to 1. In terms of what's being diagnosed, the ratio is 4.6 men to 1 woman. And in an international patient registry, the most prevalent mutation in the United States is V122I, which is a gene mutation seen in between 3.5% and 4% of African Americans in the United States. This comes from Mayo Clinic, and it represents mutations that were done on mass spectroscopic analysis of amyloid-containing samples. And you can see that the dominant mutation in the United States is the V122I, but the second most common is T80A, which used to be called Appalachian-type amyloid cardiac dominant. And although worldwide, V50M is reported to be the most common, in the United States, it's the third most common dominant neuropathy phenotype. Now, for the diagnosis of hereditary ATTR neuropathy, tissue biopsy is considered required. And you can biopsy any tissue because the amyloid is so widespread. So you can look in the subcutaneous fat, kidney, skin, which I'll be showing you, endoscopic, rectum, sural nerve, carpal tunnel. All of those will give you the answer and find the congruent deposits. Once you find amyloid, however, you do need to stain the congruent positive, and then you have to identify the subunit with either immunohistochemistry or mass spectroscopy. For ATTR cardiomyopathy, a biopsy is not always required. In those patients, there is a consensus guideline where patients who have a positive PYP scan, which I'll be showing, with no light chain abnormalities, can lead to a diagnosis of TTR cardiomyopathy without a biopsy being required. Again, I remind you that once your pathologist tells you that there is amyloid in tissue, you need to subtype it to be certain. Could be immunohistochemistry, but mass spectroscopic driven proteomics is probably the most sensitive. Anytime you see a patient with TTR amyloidosis, genetic testing is required to distinguish mutant hereditary ATTR amyloid from the wild type ATTR amyloid. There are a number of different pathways to diagnosis. Sometimes you'll see a patient who will tell you they have a first-degree relative with TTR amyloid. Then it becomes relatively obvious if they have sensory loss in their feet or dyspnea on exertion to screen for the same genotype abnormality in the first-degree relative. But for a general neurology practice, genetic screening of an unexplained, length-dependent, symmetric, sensory motor neuropathy, that should be in the workflow, that genetic testing is done, not to overlook a highly treatable cause of unexplained sensory motor and autonomic neuropathy. Again, if amyloid is found, confirmation of the protein subunit, immunohistochemistry, or mass spectroscopy is required to identify the specific type. This is just a web-based survey of patients to show the journey that these patients have, significant delays, a median of 3 physicians before a diagnosis, but nearly a quarter of patients have to see 5 physicians before a correct diagnosis is arrived. This is a technetium pyrophosphate scan. In the old days, this was just called a bone scan. It was used to screen patients for breast cancer and prostate cancer, but it was supplanted by CT and PET imaging. So it's very old technology and is available in any nuclear medicine laboratory. And what you're looking at is a cross-section of the thorax showing the green uptake of the LV wall, which is quite strong and is clearly not in the blood in the ventricle, but in the muscle itself, which would be diagnostic of TTR cardiomyopathy. The reason why it's so difficult to arrive at a diagnosis is that the symptoms are so nonspecific. The patient who presents with diarrhea and orthostatic hypotension will go to the gastroenterologist. The patient with heart failure with preserved ejection fraction or misdiagnosed as hypertrophic cardiomyopathy or hypertensive cardiomyopathy will meander with the cardiologist. The patient who has bilateral carpal tunnel syndrome will be seen by an orthopedic surgeon, have surgery, and off they go. And of course, for the neurologist, it's that symmetric length-dependent, so-called idiopathic peripheral sensory motor neuropathy that can be of 100 different causes, and you won't get this diagnosis without biopsy or genetic testing. Moreover, only half of the patients with hereditary ATTR neuropathy will give you a history of a first-degree family member with it. And so that, and it's a low index of clinical suspicion, can impede an early diagnosis. In addition, there's a lot of heterogeneity in the symptoms, even among patients with the same genetic abnormality within a given family. These are some of the clinical tests and findings suggestive of ATTR amyloidosis. Obviously, for the neurologist, an EMG and a nerve conduction study will confirm the presence of neuropathy, but of course won't tell you the type. Autonomic reflex testing also is very commonly abnormal in ATTR neuropathy. There's some early data looking at magnetic resonance imaging that will show thickening of the nerve root as well as swelling of dorsal ganglia. For patients who have cardiac manifestations, arrhythmias such as atrial fibrillation, low voltage, echocardiogram showing thickening of the heart walls, diastolic dysfunction, abnormalities of global longitudinal strain, but with a preserved ejection fraction, often called heart failure with preserved ejection fraction. When it's done, cardiac magnetic resonance imaging is quite specific because there'll be late gadolinium enhancement, which is quite diagnostic of amyloidosis. It's commonly misdiagnosed, and this is a litany of different diagnoses. And even in patients that have a hereditary history of neuropathy, amyloid is not often considered since there are so many other hereditary neuropathies that exist in the practice. Patients with cardiac can be misdiagnosed as hypertrophic cardiomyopathy, hypertensive cardiomyopathy. The patients with diarrhea can be misdiagnosed as inflammatory bowel disease or irritable bowel syndrome. Again, in neurology, they can be diagnosed as motor neuron disease, diabetic neuropathy. Patients do get lumbar spinal stenosis, but the pseudoclaudication is a consequence of direct amyloid deposition, and of course, very commonly bilateral carpal tunnel syndrome, including deposits in the non-dominant hand. This is just a comparative list of the hereditary ATTR and the wild-type ATTR. The key is that the wild-type TTR is dominant in the heart, where the hereditary ATTR has quite a mixed phenotype, including the heart, the nerve, and both. They can develop renal involvement. Something specific for V50M is they get vitreous amyloid deposits, which can cause visual disturbances, clouding of the vitreous. Ophthalmologists can diagnose it, and it's easily managed with vitrectomy. This is just type of pathway that you might be able to use to achieve the diagnosis. If the patient has symptoms suspicious for amyloid, which for peripheral neuropathy would be the length-dependent, symmetric, sensory motor with some red flag findings, autonomic, bilateral carpal tunnel syndrome, biceps tendon rupture, lumbar spinal stenosis due to amyloid deposition, those patients can go directly to genetic testing. For cardiac symptoms, it's heart failure, unexplained dyspnea, systolic hypotension, may be associated with neuropathy or gastrointestinal problems. Those patients, you can find the amyloid, the infiltrative cardiomyopathy using echocardiography and EKG, as well as the pyrophosphate scan I showed earlier. It is important to remember that immunoglobulin light chain amyloid exists in this population. And so part of your workflow is to measure immunoglobulin-free light chains just to exclude the possibility that cardiomyopathy or neuropathy is not directly related to immunoglobulin light chain amyloid, which is treated completely differently. As I've emphasized previously, there really is a significant delay between symptom onset and diagnosis. And I think Professor Khella will show you that there is a functional loss that is not reversible if there's a delay as short as 18 months. And the time to diagnosis is actually 2 to 3 years, And in one trial, the diagnosis took over 6 years after the onset of symptoms for 1 in 10 patients, and that's devastating. The mean time for hereditary ATTR polyneuropathy diagnosis is 4 years, and that's unfortunate considering the availability of therapy. And nearly half of patients who are interviewed indicate that they've been misdiagnosed, and it's everything: idiopathic neuropathy, Sjogren's syndrome, irritable bowel, heart failure, spine disorders, gastroparesis, fibromyalgia. And occasionally, these patients are misdiagnosed as immunoglobulin light chain amyloid and get chemotherapy, which is ineffective and contraindicated in this disorder. This is just an illustrative patient that has ATTR-FAP, and you can see the autonomic testing that's been performed and the scoring to grade the degree of neuropathy, but you can also see their skin biopsy, and you can see a large amorphous eosinophilic hyaline-like amyloid deposit that in the lower slide shows significant green birefringence, which is absolutely diagnostic of amyloid by skin biopsy, but this still hasn't told you the type. I want to summarize briefly by reminding you that there are important agents that can result in the reduction of the mutated TTR in the serum, which result in superior outcomes for patients. And the trials that will be reviewed by Professor Khella met their primary endpoints and received FDA approval because they proved that they did better for the neurological impairment, neurologic disability, and quality of life when compared with patients treated with placebo. And liver transplantation, which used to be the only available treatment, is now done very, very sparingly, if at all. We haven't solved all of the issues. Questions are going to be, what about patients who are identified as carriers but haven't developed symptoms yet? These trials were not done in patients who already had a liver transplant, and the safety is not widely understood. At this moment, these gene silencers are not yet approved for familial amyloid cardiomyopathy in the absence of peripheral neuropathy, and there hasn't been extensive testing in patients who have autonomic neuropathy only, and there was no testing done in patients with leptomeningeal hereditary ATTR amyloidosis. Monitoring: asymptomatic carriers are currently not eligible for therapy, and they need annual monitoring for the development of neuropathy, carpal tunnel syndrome, and cardiomyopathy. And this annual monitoring will include assessment of peripheral and autonomic nerves, as well as their cardiac status, which could be by imaging, echo, as well as cardiac biomarkers. And with that, I'd like to thank you so much for your attention, and I'll turn things back over to Professor Khella.
Thank you, Professor Gertz. That was wonderful. Very comprehensive and clear. I'd like to discuss optimizing outcomes for patients with ATTR polyneuropathy. These are my disclosures. As Professor Gertz mentioned, there are ocular findings, cardiac abnormalities, GI symptoms, bilateral carpal tunnel syndrome, tendinopathies with biceps rupture, autonomic neuropathy, and peripheral neuropathy. This is a systemic illness. This is not a one-organ failure illness. You can see on the left there's macroglossia as well, and a typical hemorrhage in the upper lid in these patients at times. So we heard already that the TTR is made in the liver primarily, although it is made in other areas of the body, but primarily in the liver, is secreted as a tetramer. This tetramer is stable in circulation unless there is an amino acid substitution, or in the case of the wild type, for reasons that are unclear, the stoichiometric reaction shifts to the right and the tetramer misfolds and falls apart, basically, where the monomers then aggregate into these toxic oligomers and deposit in the tissues as amyloid fibrils. So you can see that there are multiple steps in this process that can be interrupted, hopefully, to stop the TTR deposition in the tissues. We looked at patients in the international registry, the TAUS registry, which was made up primarily of patients from the United States, looking at the commonality of the symptoms in this disease. Turns out that in the United States, primarily, the wild type group is the most common, and then those with the cardiac mutation at 35% of this cohort. We heard from Professor Gertz the polyneuropathy of familial amyloidosis. This is a fiber length dependent neuropathy, meaning that the longest fibers, the ones that go from the spinal cord to the toes, are the ones that are affected first. And as the neuropathy, and you can see in the middle panel, progresses to reach the knees, then the hands become symptomatic, and the neuropathy continues to progress proximally. However, the hands can become symptomatic before patients manifest with the systemic illness when they have carpal tunnel syndrome with the typical symptoms of carpal tunnel. When you look at the comorbidities in the cardiac patients in the TAUS registry, you can see that patients who had the cardiac mutation were more likely to have diabetes than those who had the wild type. The carpal tunnel syndrome, however, was equally prevalent in the cardiac mutation group as well as the wild type. So we heard from Professor Gertz that this disease was initially described in 1952, and for 40 years there was no treatment until orthotopic liver transplantation. It was started in 1990 and now has gone basically by the wayside. Now we have the stabilizers that were approved in Europe in 2012 and 2013 for early familial amyloid polyneuropathy, and these are tafamidis and diflunisal, and I'll talk about them a little bit more shortly. And then in 2018, tafamidis was approved for familial amyloid cardiomyopathy, and then inotersen and patisiran for the polyneuropathy, and vutrisiran in 2022. I'd like to just point out that the term familial, as Professor Gertz mentioned, is really not an appropriate term, as half of these patients don't have a family history. And I prefer, and I think the literature now reflects more the term hereditary amyloid polyneuropathy. So when we look at the phenotypes, the V30M, which is the third most common type in the United States, but still occurs, can occur at a young age. So patients in their late 20s, early 30s can develop a peripheral neuropathy that is progressive and ultimately fatal unless treated. When those patients are in their mid-50s or early 60s, they can develop cardiomyopathy, as you can see at 1 o'clock on this cartoon. The V122I or the V148I, if you are talking about the protein, presents as primarily a cardiomyopathy, but again, about 10 to 20% of these patients will have a peripheral neuropathy, so that needs to be kept in mind by the neurologist. We don't really understand the full biology of this illness, and amyloid fragments, when they deposit in the tissues, deposit as the B fibrils, which are the full-length TTR protein, and this is primarily in the V30M patients, and the A fibrils, which are both full-length TTR as well as the C-terminal fragments. Now, the importance of these fibrils is that they may cause a different response in the patient to treatment. And you can see from the liver transplantation data that the V30M patients did better than all the other mutations. And the reason is that perhaps these fibril deposition are part of the explanation, but I'm sure there's more to be said about their responses to treatment. Now, the neuropathy impairment score is the score that is used in virtually all of the clinical trials. You have to realize that the neuropathy impairment score, which is really the quantification of the clinical examination that the neurologist does, is used in different ways in the different trials, and the endpoints are different. So you have to be careful when you're comparing trials. The MNIS plus 7 is the modified neuropathy impairment plus 7 additional tests that test autonomic function. This is sometimes used in some trials, and it's not in others. So Lowering the amount of protein, TTR, by interfering with RNA is the way we are currently treating this disease. There's the antisense oligonucleotide method, there's the small interfering RNA method, and then there's CRISPR-Cas9 gene editing method. They all work to reduce TTR, as you can see in this two graphs here, where all of the genotypes respond to the patisiran as well as the inotersen, including wild-type disease. This is, of course, the pivotal trial results from both inotersen and patisiran that were published in 2018. And you can see that the neuropathy impairment score and the quality of life were both statistically significantly improved compared to placebo. I think also one of the highlights of this graph, of all of these graphs, is the progression of this neuropathy. This is a progressive neuropathy that you have to keep in mind when you see patients in the office. And as Professor Gertz mentioned, the open label extension data revealed that the patients who were transitioned from placebo to the active treatment arm improved the neuropathy, stabilized, but they did not improve in the neuropathy impairment scale, nor did they improve in the quality of life as those patients who were originally treated with drugs. So you have to treat as early as possible. The open label extension for patisiran also showed the same results. Now, the second generation TTR silencers, vutrisiran and eplontersen, are drugs that target the liver primarily so that you can use a smaller dose and have less side effects, and you can give them at longer intervals than the original inotersen and patisiran. These trials were both done with the historical controls as a placebo arm. It's of course not ethical to use historical controls in a fatal illness when there are FDA-approved therapies. And again, both eplontersen and inotersen, as I will show you, showed statistical significance in improving the quality of life and halting the progression of the neuropathy. This is the same data for vutrisiran as for inotersen, as for the genetic carriers is become a problem. So what do we do with those patients? Or what do we do for patients when silencers are not available? I think one possibility is to use a non-steroidal anti-inflammatory, diflunisal. Now, this is a drug that is very well tolerated in most patients, although of course there are caveats for using a non-steroidal in patients who have gastrointestinal disease or very severe heart failure for other reasons. And this drug will stabilize the tetramer very much like tafamidis does. And it has been shown to reach the primary endpoint in the diflunisal against placebo trial that was done earlier. Now, what's on the horizon for this disease? CRISPR-Cas9 therapy, I think, is a very exciting therapy. And in a small group of patients with hereditary ATTR polyneuropathy, the administration of the NTLA 2001 was associated with very mild side effects, and it led to decreases in the serum TTR protein concentrations through targeted knockout TTR. Now, I think the caveat and one of the concerns that I have about this form of therapy is what happens when TTR is lowered for decades. So in a patient who's in their late 20s or early 30s, when you lower TTR, we don't really know exactly what would happen to that patient. So, and I think there's not enough data, and I think this remains a question that we need to keep in mind. Now, what to do for leptomeningeal disease? Professor Gertz mentioned the ocular manifestations. There are also cognitive impairment that can occur in this disease: headache, ataxia, stroke, subarachnoid hemorrhage. Now, who gets leptomeningeal disease? Patients with V30M, and then some of these other rarer mutations can develop this. It turns out that tolcapone, which is approved already for Parkinson's disease, can, with high affinity, lodge onto and stabilize the TTR that is in the leptomeninges because it does cross the blood-brain barrier, whereas the other drugs that we currently have available do not cross the blood-brain barrier. And so it inhibits the aggregation of this, of the fibrils. Now, studies in cardiac amyloidosis, but these have not been done in neuropathy with doxycycline and TUDCA, show some early data to suggest, although it's not widely used because I think the data remains equivocal for fibril disruption. And then monoclonal antibodies is another means of treating this, and again, studies are ongoing for this. So I'd like to summarize by saying that you should consider amyloidosis, as Professor Gertz mentioned, in a patient with a progressive neuropathy who has a prior history of carpal tunnel syndrome, who has a comorbid heart failure that is unexplained with a preserved ejection fraction, who has autonomic symptoms such as early erectile dysfunction in a younger man, intermittent diarrhea and constipation, another important feature of this illness, and a very severe one as well. You need to confirm the diagnosis both by genetic testing and then finding evidence of amyloidosis in the tissues, whether it's by a pyrophosphate scanning in the heart, which doesn't require a tissue biopsy in some cases, and or by doing a tissue biopsy such as a skin biopsy or another tissue in a patient who has a progressive neuropathy. And if you find amyloid in that patient, I think it is enough to say that the neuropathy is progressive and is consistent with amyloid neuropathy, and you don't necessarily have to find the neuropathy in the tissue because sometimes it is not present in the peripheral nerve, as it can be spotty and perhaps affecting the nerve upstream, yet causing the neuropathy downstream. The question of starting therapy as early as possible, I think, is reasonable and intuitive for all of us, but I don't think that there is enough data, and there are currently guidelines being written to try to answer and give an expert consensus as to when is early. And I want to thank you for your attention. Now I turn it over to Professor Peltier.
Thank you, Dr. Khella. So I'm going to mention several cases that I think illustrate the complexity of diagnosis and the different ways that these patients present to their doctors, and why, as Dr. Gertz mentioned, these patients may have seen multiple doctors before their diagnosis is arrived at. Here are my disclosures. So one of the things that I think is important to recognize is that the time period during which these symptoms occur is variable, but generally for most mutations, and I'm going to speak especially about V122I, which is the most common mutation in the United States, but this applies to generally most all of the mutations, is that the carpal tunnel syndrome is almost always the first presenting way that these patients will arrive at, to their doctor. Now, that being said, a lot of patients will actually have carpal tunnel symptoms, but may not necessarily seek medical advice. And so by the time they actually see a doctor, they may have quite advanced carpal tunnel when you actually evaluate them. And then years later, after the carpal tunnel, they may develop erectile dysfunction, paresthesias, neuropathy symptoms, and then start at concurrently developing heart failure symptoms with dyspnea. As we talked about, their common presentation heart-wise is a heart failure with preserved ejection fraction, or HFpEF, as the cardiologists like to call it. They also will often have lumbar stenosis, and so all of these things can also make the diagnosis muddy because sometimes patients will attribute the neuropathy symptoms to their back, and sometimes it can be hard to piece apart which symptom is coming from where. So here's an initial patient, and these are all patients that I've seen and treated personally. So this gentleman had an initial spine injury when he was actually in Desert Storm. He was a Navy veteran. That was back in 2009. And then years later, developed carpal tunnel syndrome at 2016. He then started actually having problems with being unsteady on his feet, had significant foot drop, erectile dysfunction, and had a concurrent diagnosis of diabetes. And because of the significant foot drop and weakness, a doctor told him that he had Charcot-Marie tooth inherited neuropathy, even though he did not actually have a family history of other family members with neuropathy, just family members with heart failure. So when we saw him in our clinic, we actually screened him for V122 or for TTR mutations. And sure enough, he actually did have the V122I TTR mutation. But because of all of his other diagnoses, he and his wife felt that they really wanted to get a specific tissue confirmation. And as Dr. Gertz said, that's obviously very important to confirm that you have the right mutation. He actually was seen by a cardiologist, and at that time had no findings of heart failure, had a normal echo, normal EKG, and a normal PYP scan. And he had very well-controlled diabetes, so his foot drop and significant weakness was pretty atypical for a diabetic. So we started with the least invasive test first. So we had a skin biopsy, which confirmed neuropathy, but did not show any amyloid deposition. He then had a nerve biopsy, which again confirmed neuropathy, but was negative for amyloid. And I will mention that nerve biopsy in this condition is only about 50 to 60% sensitive because, as Dr. Khella also mentioned and Dr. Gertz, it can be very spotty. So then he said, well, why not get a cardiac biopsy? And we said, well, I'm a little concerned about doing a cardiac biopsy, a little more invasive than the other tests you've had, and all of your cardiac tests have been negative. But his cardiac biopsy was indeed positive for amyloid and confirmed TTR. And so we did actually confirm that he had TTR in his heart. And I think that this does demonstrate how these patients can develop neuropathy years before they have symptomatic cardiac involvement. And also all the different challenges that we encounter with biopsies because of sometimes the low sensitivity we have. And so his examination was also pretty typical for amyloid in the sense that he actually had proximal and distal weakness as well as absent reflexes and significant absent vibration and pinprick sensation and decreased pinprick all the way to the hands. And like I mentioned, that would have been atypical for a diabetic with the short duration of diabetes that he had at the time. So the second patient that I'm going to talk about was actually a patient who was an active cardiologist. And he had a family history of a brother who had cardiomyopathy. And he actually knew that his brother had amyloidosis. In his 40s, he actually had tingling in his hands, which had come and gone, and he was not doing any interventional stenting or anything in his practice, and so he really wasn't concerned about it, and then started developing numbness in his feet and unsteadiness on even ground. So in 2019, he was convinced to get genetic testing and found to be positive for the V122I mutation. And as we mentioned, this is a fairly common mutation in African Americans, and up to 3% of African Americans may actually carry the mutation, but it's incompletely penetrant. So it's hard to know whether or not somebody who carries the gene may or may not develop symptoms. And he actually had an EMG that was done in Chattanooga, which showed that he had significant, still prolonged median motor latencies, as well as an axonal polyneuropathy. He did not have significant autonomic symptoms, and he had, as previously mentioned in the other patient, workup for cardiac disease, which was negative echo and negative PYP scan. So he was initiated on patisiran treatment, and his exam has been stable for many years. And the thought is that by initiating treatment, we are hopefully then forestalling any cardiac involvement that might be happening down the road. Now, he also had a milder neuropathy compared to the other patient, and this goes to show how you can have a very different neuropathy even with the exact same mutation. So this patient had a very normal strength. He had no significant atrophy on exam. He did have absent reflexes throughout, and he had vibration and diminished at his toes, but actually had relatively preserved pinprick and temperature sensation. And so even though we often think of these neuropathy presentations as one way, for example, small fiber neuropathy predominant, they can actually present in a variety of fashion and different types of neuromodalities being affected. So the last case is a 64-year-old woodworker who initially presented to his doctor for numbness and weakness. And because it was primarily in his legs, he had imaging which suggested spinal stenosis and underwent a lumbar decompression. He was also noted that same year to have carpal tunnel syndrome, and he had bilateral carpal tunnel syndrome, which was severe in his right hand, but still relatively significant on his left non-dominant hand. And then in 2018, he was referred to a neuromuscular physician, and he had, on workup of his neuropathy, very prolonged latencies, and because of his significant weakness on exam, there was concern for chronic inflammatory demyelinating polyneuropathy. But he was tried on IVIG, which is a typical treatment for this neuropathy, and there was no benefit. He had at this time already lost 30 pounds. He had previous heart disease and had previous cardiac bypass, and he had significant lower extremity edema. He finally underwent genetic testing, which showed a T60A TTR mutation. And he was also noted to have daily diarrhea that nobody had noticed on his history, and already had significant ejection fraction deficit. And he was referred for treatment with patisiran. And at that time, in 2018, he had about 4 hip flexion weakness, and at that time still had relatively normal reflexes, which may have been due to his spine disease. And then in 2019, he had weakness in his hands and worsening weakness in his legs. Vibration was reduced to his fingertips and his ankles, and his reflexes dropped out as his neuropathy progressed. And so that patient is also very illustrative of the complex journey that many of these patients go through and the misdiagnosis they can go through, and just having, but yet still have the trifecta of autonomic or GI symptoms, carpal tunnel, and neuropathy with or without cardiac manifestations. And so part of the goal in this series is to try to remember that these are kind of the key presentations that happen invariably in most of our patients. And with that, I'll turn it back to Dr. Khella.
Thank you. That was wonderful. I would like to ask you your opinion about the proximal weakness that is seen in this neuropathy. And what do you think, how do you approach that?
So there's been reports of patients also having amyloid myopathy, and actually if you do muscle biopsies in some of these patients, you can actually see amyloid deposition in the muscle. And then also on nerve conduction studies, they also have demyelinating features, and so with conduction block, and some of our patients have had significant temporal dispersion. So I think the question is whether or not you have spotty intermittent amyloid deposition in proximal and distal nerves, which can give the proximal and distal weakness, or if is it a concurrent myopathy, or on top of that, you also may have spinal stenosis as well. So I think sometimes it's hard to tease apart. I think the real important thing for us is to recognize that that's not an uncommon presentation.
Yes. So Professor Gertz, if I may ask you, you see patients with monoclonal gammopathies, of course, and they have amyloid. And how do you approach these patients?
Yeah, I have to comment because I've certainly seen patients with Charcot-Marie-Tooth. That's been there. I think with your third patient, I was impressed because I'm positive if the laminectomy, the posterior laminectomy from the lumbar spinal stenosis was stained for amyloid, it would have been found in the ligamentum flavum. And I think we're dealing in a highly subspecialized culture, it's like the blind man and the elephant. The cardiologist is not asking how the patient's feet feel or carpal tunnel syndrome. The neurologist is not focusing on the dyspnea on exertion that the patient has. The gastroenterologist, frankly, could care less about heart failure with preserved ejection fraction or your feet are numb. Go see your specialist for that. One of the real problems with ATTR amyloidosis is that 20 to 25% of these patients have monoclonal gammopathies. And the reason that's a problem is there might be an individual who would see an amyloid deposit and an M protein and say, this must be immunoglobulin light chain amyloidosis, chemotherapy, which that's going to be a disaster. And so it really goes to the fact that once you've identified amyloid in tissue, it's absolutely essential that the amyloid protein subunit be typed. Some labs use immunohistochemistry, but quite frankly, I found that to be misleading, nonspecific, and insensitive. And even though it's not widely available and it is expensive, laser spectroscopy and microdissection and HPLC analysis of the protein subunit is required. So in patients, the hardest part of all would be the patient who has a positive pyrophosphate scan and a monoclonal protein. With current consensus guidelines, that patient cannot be diagnosed as having ATTR cardiac amyloidosis. Tissue for identification is required because you don't know whether a monoclonal protein is an incidental finding of no consequence at all because it's prevalent in the elderly population, or really is a sign that the amyloid may be of light chain derivation. And then it's chemotherapy, not gene silencing.
Yes, I think this is always a problem that we certainly discuss on our morning amyloid calls at Penn. So if I may turn, and you showed very interesting V122I patients who have a neuropathy and not a cardiomyopathy, which is contrary to what most of the literature shows.
Right.
What would you advise neurologists to do in thinking about this, and so to prevent them from getting fatigued in testing for TTR when they see a patient with a neuropathy such as those you presented? When should they test for TTR?
So I think that it's important to test for patients who have aggressive developing neuropathies, especially even if they have demyelinating features, if they don't respond to typical treatments for demyelinating neuropathy, and also to remember that it is actually prevalent in African Americans. I think one of the misleading parts of the literature is the fact that a lot of the cardiac predominant mutations in the United States, a lot of cardiologists depend on symptoms, and many of these patients actually do not complain of pain. In our patient series, only about 30% of patients actually complain of pain. And so I think that the neuropathy is also underdiagnosed in that particular mutation, and I think it's probably more prevalent than what has been previously recognized. But on the other hand, the one caveat is that they also tend to have less predominant orthostatic hypotension and less severe GI manifestations compared to other mutations, which I think also tends to help that particular mutation fly under the radar compared to other mutations like B30M and T60A, where the autonomic symptoms can be profound, extremely disabling, and as well as a neuropathy. And so I think that's part of the reason why they probably have not been as highly diagnosed. And so the question is always, when you do evaluation of prevalence, what tests that you use to diagnose the neuropathy. And so if you don't use sensitive tests and specific tests, you may miss it.
Yes, so speaking of specific and sensitive tests, as a hematologist oncologist, when you see these patients, is the bone marrow a good area to test, or what is your area of preference for looking for tissue?
So I just have to refer back. I mean, I think these two patients with the V142I that were diagnosed with neuropathy only, I mean, you've saved their lives. I mean, because you diagnosed them before they developed their cardiomyopathy. So it's a big deal. And I think as we begin to understand the disease more, you know, thinking about, well, V142, they develop cardiomyopathy first, well, then it's a self-fulfilling prophecy because we're not going to be looking for it unless there's cardiomyopathy. So that was, I think, brilliant. And I have to say that in the practice, I feel bad. Obviously, my patients have been seen first by a neurologist, which I certainly wouldn't qualify as. But if the patient has a glycohemoglobin of 7.5, that's too bad for them because they're going to be diagnosed as diabetic neuropathy. If they have 2 beers a night and no one else knows what's going on, they're going to be said it's alcohol related without a real investigation as to what's going on. In terms of making a tissue diagnosis of ATTR, it is complicated because the bone marrow is a very good test for AL amyloidosis. It's really not very good for ATTR. 15%, 20 maybe. That's, I think, a pretty low yield as a go-to in a patient with ATTR. I think, as you mentioned, skin biopsy is a much better place to look. And even if they don't have cardiac symptoms, a PYP scan would be a clue. Sending the genetic studies. Even the subcutaneous fat aspirate and the lip biopsy, which we use a lot in AL amyloidosis, they're pretty low yield in ATTR. So those biopsies kind of depend on the, you know, type of amyloid you're really looking for. In Japan, where the V50M is extremely common and stomach cancer is extremely common, they've gotten used to doing endoscopy. They'll scope, there's an endoscopy suite on every corner in Japan, frankly, and when patients are suspected of having amyloid neuropathy, they get endoscopy and gastric biopsies, which actually are a good source.
So I want to go back to the proximal muscle weakness. Because I recently saw a patient with isolated proximal muscle weakness who turned out to have TTR. But I also wonder about the, and there's some literature to support this, and I don't know if this has been your experience as well, wild type presenting with a myopathy and not a cardiomyopathy, but with a peripheral muscle, skeletal muscle myopathy.
So there has been that discussion, and if you think about it, it makes sense. Why would wild type behave differently than hereditary TTR when it has all the other features? It goes to the heart, it goes to the ligaments, it goes to the carpal tunnel. So why not neuropathy? And I think that's one of our questions has always been, well, you know, about 8% of elderly patients have neuropathy, and you don't always know the reason why. Could it also be wild type? And because, as we've seen in many of our hereditary patients, that it tends to go to nerve and ligaments before it hits the heart in significant fashion to present with symptoms, are they just underdiagnosed? And I think that's one of the big question marks that we have and the work that we need to do.
Yes, I agree. And I think we can't stress enough, and I think you've stressed it well, the need to type the protein once you get it from the tissue. And I think even at institutions where they see a lot of amyloid, sometimes this is not done, and this is so important to have a rapport with the pathologist, with the hematologist, with the cardiologist, and the neurologist, so that they can all go back and forth. And this is really a team effort in treating these really complicated patients.
And I think one of the things that we could do for early diagnosis is try to encourage our orthopedic and neurosurgeons who are doing these surgeries, instead of chucking the tissue in the waste bin during surgery, if they could send it to pathology, I think that that would identify patients earlier in their journey. I think the thing that we struggle with is, as you mentioned, Dr. Khella, we don't know what the long-term issue is with suppressing these protein long term. And so the question is, because we know carpal tunnel, for example, will predate neuropathy and cardiomyopathy by decades often, well, is it safe to start somebody at the time of their carpal tunnel, or do we wait until they develop other symptoms? But then the problem is if you wait, now you've lost whatever they have developed because they don't get it back. So I think that's one of our treatment considerations that we have to consider.
I agree with you. I would love to hear your opinion about getting tissue from orthopedic surgeons during carpal tunnel surgery.
It's pretty important, but what we've learned, I mean, all you have to do is see the patient and ask them if they had carpal tunnel syndrome and say, when did you have carpal tunnel syndrome? And it's 5 to 10 year lead time between the onset of carpal tunnel syndrome and symptomatic peripheral, autonomic, or cardiac symptoms. But at least you can start them. I certainly wouldn't treat a patient because with that latency, and there's nothing approved for asymptomatic patients. But I'd certainly at least begin them then on the monitoring and observation and bring them back on an annual basis, anticipating it may be 5 to 10 years, but at least I'll be able to start them at the very earliest onset of paresthesias, EMG abnormalities, pyrophosphate uptake, something that would say this is real.
Well, I think there remain many questions that need to be answered here, but certainly this is a wonderful thing for patients and really an exciting time in this disease. And I thank you for your attention. This has been really terrific.
Thank you.
Thank you.